before going to school, in addition to doing that, I want to campaign for the gender free appointments. What I do, that's all I'm walking along the town line in the exterior aspect of the festival, with one of the aspect of the government. I'm walking through the extra.
Why don't we take a 10-minute break and then we'll come back for our final hour. You can't get it all in one day anyway.
Yeah. And it's going to happen. It's
When I read the brochure, I thought,
people that want to lose weight, if you do the thyroid frequently, like twice a week or 3 times a week, you find people that lose weight rather dramatically, especially if you combine it with color therapy that I mentioned earlier. There's a number of German weight loss clinics that just do that alone. They put people on a diet that's sort of equal to the diet that most Americans eat anyway. No, I mean, most Americans eat, and I have to admit that, a better diet than the average European does, which is not generally known. Yeah, which is a bad sign. And they give a thyroid injection every day for 3 weeks. And this gives a tremendous weight loss in people. This is usually very much lasting. And they also include the points that are on the stomach meridian, which involves they look at the wisdom teeth, they look at the sinuses, and they look at the gynecological area. And do those a few times too. But mainly the weight loss clinics there are based on just simply doing repeated thyroid injections. Now, I have, what we're going to do here, this is not therapy. I'm going to demonstrate the injection in a minute here, and I've had more grateful women from this procedure than any other single modality or procedure that I've done. It's very, very dramatic. If you have a woman in a premenstrual situation, give her the simple, harmless injection, automatically study. If you combine it with a pelvic block, you get much more lasting cuts or changes in PMS. And I consider it the PMS treatment. Thyroid in the gynecological area, it's really quick, it's dramatic, and it's lasting. Ganglion block, I just heard you had that demonstrated yesterday, so we're not going to repeat that today. So I'm just going to show you the thyroid. The thyroid, in a way, is sort of a small version of that treatment, often alone, on its own, it's not lasting. In combination with the fact of the ganglion block, it makes it long-lasting or forever. I find that in women that are still premenopausal, usually when you do these procedures, they're not lasting forever, but they can last for many months or for a couple of years at a time. But when they're sexually active, and I think that's probably the most activity, it does tend to recur. There seems to be sometimes be stirred up just by the simple fact of sexual activity or whatever is connected with that. In my experience, post-menopausal women, when you treat them, they have a certain amount of tension or depression or hormonal stuff related to the gynecological area. They're often lasting relief for just doing 1 or 2 thyroid injections or 1 or 2 thyroid injections in one kind of ganglion block. But in women that are in childbearing age, these injections are very dramatic and very lasting, but not forever. Women tend to come back after a year or 9 months or a year and a half and say, could I have one of those injections again? How is so much last time? And I bet Gary also agrees that there's a lot of nutritional ways of treating that by using even primrose oil or magnesium or this whole line of other things that are beneficial. And my feeling is by combining this approach with the vitamin approach, you can relieve most women of all the female walking our way down and we talked about this. For the testing, would you just all step back slightly so that you can see how initiative. Actually, let's start with the the way I do the teeth and random stuff is I kept saying to one finger flat in the row or quadrant. No, flat on the So there's a couple of places you got the pelvis, the thyroid, and the middle of the so if you start with thyroid, always the first thing I'm doing and check back to the pelvis. Often the pelvis goes away when you do the thyroid, because it's a block in the stomach where you do the thyroid and all parts of the so one finger on the sternum notch. So, the other one to determine whether the thyroid part which is, you go and point the midline. You see the anterior sternum disease here. So one inside of it, in the middle. Is anyone clear on this? So at half the distance between the sternum notch and the Adam's apple, take the midpoint of that, go out to the side, and stay on this side, leading to the sternum clavus, which is here. So put the pointers to the feet, and then this up. Aspirate, turn 90 degrees, aspirate, and put down to sleep. This is a very famous injection compared to some of the others. Want the patient something? Sometimes we can 2 fingers down from the lower point of the malleolus. There's some dispute, some discussion of whether 0.7 is or so. But I take that one. You take the tip of the malleolus in the middle and go about 2 fingers down. And this one doesn't have to be tender.
Like gallbladder 62.
But in her case,
Does it look like those gathers?
in her case, there is a little skin elevation here. And I also look at those sort of things along the acumen contact point. I think it's very important to get the personal location of the point. There's many different ways of determining that, of course. But I use often like there's a little elevation, a little dimple in the skin. In her case, I go just below elevation. They make a nice little button. Same point on the other side. So you take the tip here, about 2 fingers down. This again like a little skin bump, which I like to get. I find it a very good way to localize acupuncture point to look at abnormal pain in the skin, the dips or the mountains or the coloration. You can also use the VAS, but it's still far away. But I do that very frequently with the upper extremity, take your pulse like this. Setting everything right here, knowing approximately where I want to go. This is 1 finger below the tip of the medial malleolus. And we have the VAS, the pulse tank. This is where my injection goes. Now, here you often get a little vascular indicating oscillation in some of these conditions. Moving parts like the head. So there's something that should be able to do this. Successful. And that's already.
Gallbladder 62.
I'm sorry. There is 62 on the outside.
On the outside. 60, yeah. 6, yes.
6. So 2 fingers below on the outside, 1 finger below on the inside. I think that's most of it. And the point, 3 fingers above. Now there is a lot of additional pointing all in your book, but this is what I'm doing for insomnia at the first round of treatment, and it's very, very effective. It usually works universally the first time you do it. It doesn't necessarily works for many nights because there's so many other things dealing with insomnia and sweating the nights that way. So I can almost predict it and switch it over to the Okay. Now, we got a few more things to cover. I'd like to speak a little bit about the shoulder joint just for 2 minutes. I know we're running out of time soon. The shoulder joint, one of the things that I've learned from our common teacher, man, only and modified from him. If you have adhesive capsulitis of the shoulder, like our patient from the school, and if you're willing, we could demonstrate it on you. If you have your shoulder diagnosis right, if you got not caused by muscle and not a bursitis, then often with a single injection you can relieve lastingly get the shoulder well. The way I do this is this, the posterior approach, putting not only 1 cc or 2 cc like the neural therapists do. I'm shooting again, going back to my chart that I showed earlier. I'm trying to get many different, I'm trying try to address as many pain components as possible. And when I treat a shoulder joint, when I treated the neural therapy way, I put 1 to 2 cc of local anesthetic in the joint, addressing the electromagnetic disturbances that may be there. If I use 20 cc, I'm doing two things. I'm also separating the adhesions, the scars within the shoulder joint by forcing so much fluid in there. That means I'm addressing both the electromagnetic component and the structural component. And since it's the same needle stick, rather than just using 2 cc during neural therapy, I use 20 cc, addressing both the structural and the neural therapy aspect. And that way you get very, very dramatic improvements. And you can then add in an ampoule of Traumil and an ampoule of Zeal, which I've not found to be unsterile, like the Coop products. You can also add in the immunological biochemical aspect and then cover 3 aspects with just 1 injection and get very, very dramatic results in these people. And maybe we hold back a little bit, but if you're interested, I would love to do this on you tonight because I know it will probably resolve your problem. And then we mobilize the shoulder right afterwards because now you got a pain-free shoulder. You can mobilize and tear up the adhesions and have a very dramatic improvement. And in the most severe cases, I've had to do this up to 3 times, never more than that, at about 1 or 2 weeks intervals, which is a wonderful treatment that you won't find in any orthopedic textbook or any other textbook. Moving down from the head, we've discussed some injections on the head. The I forgot the sphenopalatine block. It's very simple to do. The main secret there again is to have the right needle. Sphenopalatine block, different from the Dodge book, which doesn't give the accurate location. The arch of the diagrammatic arch here, you take the midpoint of it, you move slightly above it, about a quarter of an inch, and aim at the wisdom tooth, or the upper wisdom tooth on the opposite side. This is your needle direction. And you use 1 or 2 needles you can use that I found safe. One is the 25 gauge spinal needle that we just showed here. The other one is the 2-inch needle, 2-inch 25 gauge needle from BD. That's not a spinal needle. They both have fairly blunt tips, which avoids puncturing major blood vessels. It pushes the blood vessels to the side rather than puncturing them, and you're just not going to see the hematomas that we talked about yesterday. You're just not going to see it. It's a very safe and effective injection for treatment of headaches, facial pain, and TMJ problems. It's a very important injection. I have not found it to give me very much lasting relief, but sometimes it's the last resort in acute headaches. Talking about headache, another little secret for you that you will be very grateful for, the treatment of acute migraine. Now, the treatment of acute migraine is difficult, as you know, with acupuncture. Anyone who's honest will tell you that they're having difficulty in relieving acute migraine with acupuncture. And anyone who's honest in neural therapy will also admit that it's difficult to treat an acute migraine with a 2 cc IV shot that's promoted in neurotherapy. In neurotherapy, then they go to a combination of doing 2 cc IV and injecting the painful spots on the skull in whatever area the patient is hurting. I found that it's effective in every kind of headache except in the true migraine, in aura and the typical events. I didn't find that working. What I found worked was this. I draw up 10 cc of 0.5% lidocaine or novocaine in the syringe. I add in 1 handful of geranium and 1 handful of spigolone.
Get a different
There's one over there to the right, on the TV. One on the right.
Geranium is the main remedy for headaches stemming from the neck, and spigolone is the main homeopathic remedy for spasms of the vasculature in the brain. And I have to correct myself. If I use the homeopathics, which I don't always use, I'm using 1% lidocaine or 1% novocaine, and draw the total up to a total of 10 cc. Yeah, so with a 10 cc syringe, I draw up my 2 homeopathics, then a 1 cc, 1% home. That's from here, they only come in one size.
Stanfield, 1 cc.
They're 2 cc handfuls. So you got 4 cc homeopathic and 6 cc 1% lidocaine or 1% novocaine. Alternatively, you can use 10 cc of 0.5% local anesthetic and 50 milligrams of Benadryl for the physicians in here that don't frequently work with homeopathics. This gets injected now over about 5 minutes, slowly IV. And usually within an hour of this injection, the patients are completely pain-free, have a clear head, and migraine is gone, they don't need any other treatment. It's very, very dramatic. The interesting thing was when I was just in Spain on this big conference, that the latest treatment for cancer pain that was discovered by an English team is exactly this injection, which I discovered 5 years ago after listening to a conference in Las Vegas. Somebody promoted this for migraines. I've been using it many times. It's very, very effective. If you can combine it with traction to the neck, to the cervical spine, about half an hour after this injection, it seems to be working every time. If you don't do the traction of the cervical spine, there are some people that just improve and need another injection the next day. For cancer pain, you use the exact same injection without the homeopathics, but use the 10 cc 0.5% local anesthetic and give it once, and usually it gives complete pain relief for about a week. Rather than having people on morphine and heavy drugs, you just give them a little shot once a week, and they're pain-free for many, many months, just go before they die. And it's been a most remarkable, amazing treatment. And I was very glad that that was discovered by somebody else also, so we can do it officially now.
Not just that.
The researchers from England take 10 cc, either 0.5 or 1%. They have made up their mind which one is better. I've used only 0.5%. What the patients describe usually is this, that they feel a numbness from starting from their feet, slowly ascending, as if they're sort of filling up with some numbing agent. Very interesting feeling. And the headache is usually the last part that disappears. Look at that headache.
These also get some ring in the ears and some bell pieces in the mouth.
They don't if you muscle test them before and they test okay before you. And it's very interesting. I've seen that only before I use the muscle testing. With the muscle testing, sometimes you don't find a local anesthetic that's quite as strong, and then they get a side effect. But they don't seem to get it when you test out for a good remedy.
Do you use it for cluster?
Yes, for any type of headache. It would be nice if maybe we can, Gerald and I can give you maybe a demonstration of the serious traction of the neck, which requires another second person holding the feet and one person pulling the full body weight on the neck. It's a wonderful treatment for migraine. The interesting thing is if you treat the same patient a few migraine attacks with this treatment, the distance between the migraine attacks becomes bigger and bigger and bigger. You never see the patient again. So it seems to be a complete treatment unto itself. Usually after the first time I see a patient with this, I put them also on oral spironol and gelsemium, the drops, and give a few drops every day and have them take it whenever they have the first signs of an oral. But this is the most dramatic treatment, and since it is a treatment that belongs to the category of neurotherapy, it is a numbing of the autonomic centers of the brain. It's very, very dramatic, and you can use it for any type of pain. I've used it for low back pain, I've used it for ankle pain, I use it for pain from fractures. It's just an additional modality, and there's an extension of the neurotherapy treatment where the neurotherapist inject 1 cc of local anesthetic into the brain. Instead of doing that, we use 10 cc and get a much more dramatic and reproducible effect that does the trick every time. You can also, when people have a flu, it's just walk down the body. So we have talked the shoulder pain. So the shoulder and the IV, I use the same solution. The shoulder 20 cc. In the in IV, I use 10 cc. And with this precaution, you need to be prepared for an allergic reaction. I've never seen one, but of course, if you get a large amount of IV, the more prone of seeing a hypo blood pressure drop that you would have to be prepared for. So people using this modality should have IV equipment there to potentially give IV. I've done many of these injections and never had any problems with it. And the English researchers never had any problems in their 2000. But, you know, you will be probably the first one to have to get there and have an IV equipment there. And this is the most monitored treatment. Simply that requiring instinctive difficulty, you know, you have to find the topic of appearance field, and then you go and eliminate your false start. Do your scars, do your tonsils, which are frequently involved in migraine headache, you do the teeth, and you have time and the patient is already pain-free, but already you demonstrated to the patient already that you can deal with the problem, and you tell them that, you know, the migraine was there as a warning flag, and now you take the warning flag away, you still want to go after the focus causing it. So this is a wonderful way of approaching migraine headaches and pain. Going down the body, the chest is a very important interference field that most neurotherapists forget. Most neurotherapists forget because it's so, the treatment that appears to be so superficial. And anyone here having any problems with asthma or any untreated chest problems that will be volunteering to demonstrate this technique. Okay, so that'd be a good thing to start with. The chronic dry cough always makes them also be the stellate ganglion blocker. The dry coughs very frequently are rather caused by the nerves leading to the chest muscle innervation rather than by the lung itself. But it's about half the cases with the chest itself. Thanks for volunteering. Ed, would you draw us up about 10 cc of local anesthetic?
You're good at
They're gonna be calling me his supplier.
You charge me later for this. And is the lady here with the neuromas at the foot? Okay.
10 cc.
10 cc's, yeah. And the yellow, well, no, let's take the fine blue needle. What?
Fine for it was.
Fine blue needle. And
30.
the only other thing we're missing is the prostate and the pelvic injection, which we may have to demonstrate or not, and then I'm going to use you for the neuroma. So that's another sort of personal discovery for me that I'd like already go home with such a dramatic discovery. How long did you have the glaucoma?
8 to 10 years.
Okay, will you go back?
Before you get off the subject of the 10 cc's of IV you briefly mentioned the fluid.
0.5. 0.5.
0.5. You briefly
It's 1% if you dilute it with homeopathic.
mentioned the fluid. You briefly mentioned that. Someone mentioned what do you mean the passage period every day? Is it revolving?
I've just seen that people get the shot within 2 hours, all their oncology group running.
How about if they go full-blown case of fever?
Usually, I live in an area in New Mexico where most of my patients are Hispanic, and when they have a flu, they call in, "Doctor, I can't come, I'm sick." So I haven't had a chance of treating acute flu here, quite honestly. And with acute flus, there's sometimes some people think that the incidence of allergic reactions is higher when somebody has a full-blown illness. I don't know if it's true or not, but I would definitely assure you one person before. Maybe just as a normal neurotherapy treatment would be maybe 1 or 2 cc's of lidocaine. That's probably what I would do in a acute excessive. It's already full-blown in the fever and then everything else. And very nice to combine an injection with reactive pharmacology. so 10 years ago, we had at the onset of this, do you remember preceding that any particular illness or trauma to your body?
Got a, I was trying surgery, going through, and I got a lift something down.
Okay, so he had an inhalation of some toxins that preceded the onset of this trauma. Now, in this case, of course, the homeopathic master would immediately think to detox him, put him on a fast and so on and so forth, and then maybe make some homeopathic stuff with an oxide, which I do, by the way, in a way if I can't get the proper homeopathic, I try to get the original poison homeopathically prepared myself and muscle test the patient with the potency until I find the one that makes him strong. And that's the one I give to him. This way you can, on your own, in your own lab, make the appropriate right homeopathic, and you check them back every week. If it's still the right potency, usually you go up to the potency. Yeah, and the way you do it, like in this case, you will try to get some of the stuff, mix it with water, shake it for 2 minutes, take 10 drops or so of that in another bottle of water, shake it for 2 minutes, take 10 drops out of that in another bottle of water, shake it for 10 minutes or 2 minutes, and or 100 times the other rule, and go on and test it with each potency, and test them until you find one that makes them strong. And I find it works so wonderful with the chronic toxicity of people that have been exposed to things that I'm now, rather than looking through my homeopathic PDR, I have the patient come to my office, I have them buy the bottles, I have them buy plenty of, I use Evian water for it, plenty of water bottles come in my office with the bottles and everything, and I set them up and do their own shaking. And as I see other patients, I have them sit there, and I just come back every few minutes and monthly test them on whatever potency they reach. And it works very, very nicely. And the nice thing is with that, you can also make homeopathics out of all kinds of things that they were exposed to. And the initial test is, if it's weakening them, you suspecting that there was a substance that they exposed to.
You find that works better than Korsakoff solutions? You use a lot of bottles. I find the Korsakoff was fine. Korsakoff solution, where you mix it up in one bottle, empty it out, and fill the bottle up.
I've tried that also. I was brought up, this classical thing that you need to shake it by hand, and I'm sort of, I think my belief system is in
You're a pioneer. Try it. Save you bottles. It works.
Okay, thanks. Yeah, thanks. So what Gary is suggesting, just to put the substance in a bottle of water, then empty the water out, and the drops that are still in there, moistening the wall is enough to make up your next dilution. You don't have to go through the shaking or the routine. I still would suggest at the end, maybe the last dilution that you're actually going to be using, to shake that for 2 minutes to make it last longer.
Well, I still shake it in between dilutions. Just that only use one bottle.
Okay, you still do the shaking. Okay, thanks.
You also use a vibrator, a lab vibrator, turn on for 10 seconds.
This is something I'm suspicious of because we know that the electromagnetic engine in there is setting off its own field being strong enough to destroy what we're trying to make. So there's some.
Then the least of them, 120 dilutions, they dropped it. And then they do one of those vibrators for 20 seconds.
It's interesting. Thanks for sharing that. However, I would guard you that you don't know exactly what vibrator to use and how long it is on the actual engine or to the fluid. I always tell people, and I've seen that the pure homeopathics weaken when people have them sit on the dashboard of their car too close to the instruments and too close to the electronic whatever's in the car. I've seen them weaken, and I've tested them against Tommy in my office that was innocent sitting in my office, and the Tommy that they had sitting on the dashboard, and their Tommy didn't test anymore after been sitting there for 3 weeks. So
I can give you this morsel. For years I've used a EWR vibrator, and for probably 2 years at least, every time I would discuss it with a vibrator, I would put it back in circuit and test it again. And those characteristically, 2 months, 3 months 4 months down the road, we're still active.
So, what I'm getting from this is that I can loosen up a little bit on my classic thinking, and that it's okay to use a machine to prepare the instrument, and you can save your patient the discomfort of having to shake. And
Shoulder techniques.
and it can be made a lot easier. But I recommend you try that. People that I had one dramatic patient with diabetes, a young girl at 20 who developed diabetes after she had some abdominal flu. I tested her out. She tested positive on an influenza nosocomial. I treated her with it, and the diabetes got a little bit better, but not dramatically better. And I was trying all kinds of things, and finally I said, well, she was started on some of the oral anti-diabetic drugs, which she was taking a huge amount of. And I said, well, maybe this is blocking us from getting you well. So I had her prepare the Liberide or whatever it was, kind of alcohol, one of the normal
Oral diabetic.
yeah. Anyway, I had her like grind down the pills like I always do. Grind down with one of those things you buy in a food shop.
Or,
Yeah, my English is fading.
Order system.
Okay, you grind down the pills, a few of them, dilute them with water, shake them up, and take them through the dilution process. And with her, it was like a pain. It was like a 30 or something, 28 dilution. That's strong on her. And I gave her this stuff, and her blood sugar, this kind of thing coming down in 2 weeks. It was not 120, coming around 300, 104. And I kept on the stuff, and I checked her every week. And the potency jumped up very quickly. Like every week we need to go up 3 or 4 steps. And she has had no response to diabetes, and was diagnosed as a medically insulin dependent diabetes, but it didn't really respond to all my blood pressure. And I think that's a wonderful case demonstrating the importance of looking at those simple things and really sort of underlining everything that Alberto said yesterday about detoxifying conditions. And also, like in this case, the residues of the drug were blocking the varicose. It's done its job already, but we couldn't see it because the other thing was masking everything. So you always want to think of those simple things that you can do so simply in your office without having to know any drugs and tires or just know what drugs the person was on. Now she was interesting from the first, she was still on the drug while I was detoxifying all the drugs. Until the blood sugar came down, and then as it was coming down, I was letting it take away the drug, over a 2-week period. I saw it every day, and it was like a fine therapy. Okay, you test anything else that you know that happened 10 years ago? Okay, so he inhaled some sulfur dioxide, which brought on a dry cough that has stayed with him. Now, this is one of the typical things we see often for the dry cough kind of thing, and that's sort of something I can almost guarantee would get well with a series of stellate ganglion blocks. This is something in the nervous system is not really around in my experience most of the time. Sometimes it can be around for demonstration purposes to your chest. So the most important points are the points close to the sternum on the kidney meridian that I always do first in this treatment. We want to put some nice skin wheels to determine where the sternum is, and you on just adjacent to the sternum. With these you go very superficially and make nice big wheels. They're rather unpleasant in this area, they're usually hurt. And I do a few points around here, and then I'm sort of fading it out and following a line away from the chest. get sophisticated with it, you can check for the tender spawn points and give those some preference. Like in this case, most of the intercostal spaces will be tender from carving layers. And I usually don't do that, but if somebody wouldn't respond, I would then get a little bit more accurate by combining tender point with the general idea of the segmented therapy. Now, segmented therapy and neural therapy is something that I keep forgetting many times, but it's very, very effective for gallbladder attack, kidney stones. You just kind of put as many skin wheels as you can in the area overlying the painful area. And you basically make a nice symmetrical distribution of bands of injection overlying the chest. You basically circle the breast. You go these 3 or 4 points along the sternum, and then you sort of find this kind of distribution. You can look it up in the book to get a mental image, but it's not important. The important thing is you have to be over the lung, and the more you do, the better. You stimulate, you're using the visceral cutaneous reflex. By stimulating the receptors in the skin, you get an increased blood flow in the lung underlying this injection science. And if you have a good idea where the trouble is in the lung, then you want to give extra attention to that area. And again, the most important points are the few points along the sternum and a few points paravertebral in the back. And I always start with the acupuncture points that I know. Bladder 17 is on the level of the lower angle of the scapula, in line about an inch away from midline. So that's the point where I'm starting. Very important point. And again, you don't have to be a mathematician. The rough area with this treatment is enough. The next one is roughly in the middle of the shoulder blade. You take the shoulder blade between 2 fingers like this, take the middle and the height, and go over next to the spine. That's bladder 13, which is another lung point. And those are the most important points on the back. And I just do those first to make sure I include those in the treatment before I complete the neural therapy treatment. And then the rest of the injection is lining up the points in a nice row. Now, this treatment, like I said before, some neural therapists start the first treatment when they don't have any other theory to follow. They do all the scars in the first treatment. Second treatment, they do the chest. In third treatment, they do the abdomen and the pelvis. Because, like you see, this is a quite time-consuming treatment. I have fortunately enough now a nurse that can do this. And follow the idea. There's a few important points in here, and the rest is sort of arbitrarily following a nice rounded curve around the outline of the lung, giving you the best stimulation of the visceral cutaneous reflex. Sometimes the cough, this treatment can be very dramatic. In stopping the cough, I had one person who was a famous psychic healer from Texas that moved to San Jose because he couldn't shake the chronic cough that she had. And with her, she's seen everyone. Like she's been the psychic in San Francisco, and she's had she's been on medical cures even in Germany and the roads they send her up to the mountains there. And she's been seeing all kinds of people all over the world really. And we did one treatment of never cough. I mean, never cough again. She was fine since dramatic, ridiculous little people like this, so there's not any risks to it.
You didn't know stellate?
Stellate is the second line of defense. First, always do this, and if this doesn't work, then I very quickly in chronic coughs go to the stellate ganglion because it seems to be so effective. How are you feeling? So he's feeling an improvement right away, and usually if it's that quick, you better that it's a very strong lasting. Sometimes you could go back after 2 days. Thanks for letting me demonstrate. Walking right down because we have a little time.
There's no modification of that for asthma these days.
Forward.
Asthma. With asthma, you do the same thing.
Yeah. Asthma, you want to pay very careful attention to the history. Most of the time there's interference field, and very often there's a psychological trauma we dig into with hypnosis, and I think that's been very, very important for the asthma cases that we've seen. I find asthma, there's 2 levels of asthma. One asthma patient is the easiest patient in the world to treat. You do a few things and they're well, no matter how long they've had it. You do the tonsils, obviously not the tonsils, upper respiratory kinds of things. Stellate ganglion block, the chest, and the appendix. Those are the most common things that you find. And there's about 2/3 of the asthma patients are just really, really easy. And there's another group of asthma patients are the most difficult ones. Those are the patients that know everything about medicine. They've seen every doctor. They know how their lungs look inside out. They have CAT scans of their lungs, and they've seen all the important healers in the world already, and they know they can't get better. They come to you and they want to get better. They don't want to get better. And those people sort of pretty much changed my approach now. I insist on those that they first undergo a series of hypnosis treatment. And I don't waste my time on this. A lot of people that really are so fixed on having a symptom, especially with asthma. I found that they get they're very complex nuts to crack. And usually if they tell them any 10 sessions of hypnosis, they usually don't come back. And so I don't have any experience with that particular group, but about 2/3 of the asthma patients are the easiest and most rewarding patients that you'll ever see. And they're very easy to respond to the military. The next thing I want to talk about is the pelvis. Now, the pelvis in men just as well as in women is one of the most frequent injections that I do. Now the ganglion, as I said, there isn't a single female patient in my office that didn't have one. I could tell you an incredible number of stories on the ganglion blocks, on what it did for women. Either it dramatically releases some emotional stuff that they're holding on to, and it seems to be much more so in the American population than in the German population. And I've seen dramatic reports on people remembering rapes in their childhood, child abuse type of things. Seems to be very, very common in the country. I've seen you just relieve of all symptoms, you name it, and I've seen it be released by doing a pelvic injection. Pelvic injection is a procedure that I recommend. I've never had any glaucoma or any bleeding afterwards. So I feel it's a matter of the right needle. If you use the needle that we recommend, you're not going to see the bleeding. You do the right technique, and it's a very safe injection. Men, usually about half the men that I've seen refuse to have the injection done. So I can't really report like the great success stories with men. I know in the German, amongst the German military, they all have great stories about 20%. Age over 30.
That'll be fun.
Okay, anyone let me demonstrate the needle position? Is there any woman who would let me inject her pelvis in front of everyone? Separate. If there's any women that want to have their pelvis injected but want to do it more privately, do that afterwards. But is there anyone here who wants to do it? Who would be willing to do it? Okay, well then let's just demonstrate the technique. That's probably the needle. Would any male volunteer come here? You don't have to expose anything deeper than your pubic hair. I found on most older men, this injection is a benefit in terms of the prostate problems, but also in terms of depression. Gives me significantly relief, or cheer men up. So we're just going to demonstrate here. The first instruction, first important thing when you do this injection, you send the patient to the bathroom before you do the injection, no matter when they hit their last pee. That's number one. And never forget that, please. It's just going to make life so much easier on you. And we're going to use one more of these. I know we did another one open already, we don't know where it is. I use for men for the suprapubic injection, you have to have at least a 3.5-inch needle, better a 4-inch needle. And I'm using the BD spinal needle. The reason is not that it's a spinal needle, but the reason is that it is a fairly flat tip. Okay, so let me repeat that. In women, most of the time a 3-inch spinal needle is fine. 3-inch, 25-gauge spinal needle. And the reason I like to use it is because it has a blunt tip. It pushes blood vessels away from it rather than penetrating them. And you're going to have a much lower incidence of pelvic bleeding. There has been some reported complications in Germany from people needing surgery to explore the hematoma. Three cases over the last 20 years or so. Not many, but there's been some cases, and we want to make sure you don't find them. So I strongly suggest stick with this needle, which is expensive. It's about $50 or $2 or something. But because of safety reasons, I would suggest we go with this needle rather than using any of the German needles, which have all rather sharp tips, or using some of the other non-American needles that you can get, which also have rather sharp tips. I think I'm just going to demonstrate it over TV. So, the first thing, just to take you through the steps, you have your needle ready. I take the stylus out because you really don't need it in this area. Put my 10cc syringe on it, 10cc 1% lidocaine, or 10cc 1% novocaine. Then you put your bronze stuff here again. In this case I do use betadine because of the proximity to the excretion halls of the body. Then you palpate the upper ramus of the pelvis, whatever the proper name is of the bone. It runs sort of almost horizontal across the pelvis, roughly in the line of the pubic hair. And you, in the beginning, I highly recommend that you take a pen and mark the line. And I'm going to do that before you, if I can, the right. Let's do it on one slide so your wife doesn't bother. That's the first step. You mark the line of the bone. The second step is you palpate for the artery. mark the line where the artery is. And you mark your midline. Now, when you have these marks, you're absolutely safe. You now go about 1.5 centimeters, which is in inches, about 3/4, about 3/4 of an inch. You move away from the femoral artery in, and you move about 1 centimeter up from the pubic ramus, 1.5 centimeters. Again, would be about 3/4 of an inch up at you, which will give you a point approximately here. Can anyone see that? Everyone see that? Centimeter, a little less. Depending on how far the artery is away, if you're about 2 inches out from midline, you're fine. See, in skinny girls, you're closer in up to 1.5 inches. If you're 2 inches out, you're fine. And then you basically aim your needle tip approximately at the anus. You go through the skin rather quickly. You have your, or very sensitive people are put a little bit more global anesthetic there, but if there's no needle, go through the skin rather quickly, and then sort of advance your needle slowly so it can push blood vessels out of the way. And you have, sometimes you have a thing called the innominate artery. You have an artery in this area that can be there, going up on the inside of the abdomen. And usually if you proceed slowly and move your needle in slowly, it will push the artery and any other major vessel out of the way. Arteries, they are able to contain a lot of pressure. They have a hard wall, especially in older people, and it's difficult to get into an artery. It's another thing that happens accidentally. You have to jab the needle in there quickly, and then has to be sharp needle in order to get into an artery at all. If you ever, I did that during my thesis, I had to inject a couple of thousand of femoral arteries. It's difficult to inject an artery if you want to. It's very difficult to inject it if you don't want to. You have to be really sort of going quick and rushing it. You can brush through the skin and aim at the asshole, which is about this angle, towards the midline, and in the beginning you can put one hand in the back if you want to know where it is. But if you just, in your mind, you keep an image where the prostate is. You can palpate the prostate from the other side if you want to. In the beginning, you get an accurate mental image of where it would be, and then you aim the needle at it. The most important thing is if you touch the prostate or get close to the prostate, you get a signal pain, which is a light pricking sensation that tells the tip of the penis. And since the injection is identical the same in women, except you reach the tissue you want to reach a little earlier, a little shorter needle, again you get a pricking, sharp, light sensation in the clitoris area. That when you reach that sensation, you know you're home. You've done your job, and you put 3 cc of sort of anesthetic there, then you withdraw slightly, and put another 2 cc on the way back. German neural therapists do it a little different. I sometimes, and people take up to 10 cc or 1% on each side, especially in people that I know it took a long time talking and convincing them that I need to have it in a vial injection, I need to have all the benefits from this injection. I don't hesitate to put 10 cc on each side, which gives me a little bit more room for error that my needle isn't close enough. Also, however, the tissue surrounding the prostate and the uterus is a very loose, fatty tissue, where the fluid finds its way very easily. And since we are using electromagnetic disturbances rather than trying to separate spars, a small amount getting to the right spot will do the job. The signal pain is important both for the prostate injection and for the injection in women. I get it almost every time. It's very easy. When you get a signal pain, stop the bounce in the needle, and that doesn't help you to grow. Usually it's about 2 inches in normal situation. If you're very adipose, as close to the uterus as you are in skinny women. So the needle length here doesn't really matter that much when it comes down to this. Sometimes you need more than 3 inches. I never needed more than 3 or 3.5 inches to get in the right place. I usually, when I don't get the signal pain, rather than pulling the needle out and starting again, I inject on that occasion, hoping that I'm going to get enough there. And often you find that after introducing 2 cc or so, they start getting the signal pain. So anesthetic is finding its way through the nerve plexus that you want to get. So rather than moving the needle around, I let it be where it is and inject where I am. And if I'm not getting the signal pain within my 3 cc, I'll go for 5 cc in the spot. And if I don't get it there, go for the whole 10 cc on the side and pull the needle out and go to the other side. I use the same needle on both sides. I've never seen an infection from this procedure get extra peritoneal, so I don't have to worry about an intraperitoneal injection. The only thing is the patient didn't empty their bladder before. You can get into the bladder, and I've been there a number of times. But when you aspirate to get urine back from the bladder. Afterwards, but during the procedure, you mean? No. No. First of all, I've never seen awful pain anywhere. Even people with severe endometriosis and other problems, they report pain during the procedure. But you put a little local anesthetic and wait, the pain goes away. And then now you can put a little bit more and back off. And usually by doing it gently that way, they never report any severe pain. If they do, I would suspect that you're in the wrong structure, the ureter, or directly sitting in the nerve with the needle tip, and you want to manipulate the needle with it away from it, or let it be going down. The injection itself should not be very painful.
One thing about when you're advancing, there's a time you're advancing.
Well, the advancement takes, the way you do it, like you prick the skin, and then about this movement. So it's done in about less than 2 seconds. But it's rather than doing this all the way, you go through the skin, and then sort of a gentle movement forward. It tends to go very easy at all times. However, you will detect scars. If people have a lot of scarring on pelvis, you hit the bulk of scar tissue, and you sit right in the middle of it, and you feel that you have scars, and there's a very flashing area to detect, and then use more local anesthetic, or also more dilute local anesthetic to really separate the scar tissue on your way as you're working your way forward. The only other thing that will happen is a number of times by having a needle and everything right and going down, you underestimated the extension of the pubic ramus and you hit against the bone of the pubic ramus. There's another drag, you inject about half a cc to the cc there because there's some important trigger points there. And withdraw the needle. Usually you withdraw all the way until about only this much sticks in. Then you move the skin of the belly up, and from the same needle position you then advance again, a centimeter or so higher up, so you slip over the pubic ramus. That's something that will happen when you do the procedure right routinely, but you try to slip it in as close as possible over the bone in order to avoid getting into the needle. So you have to compromise between those two. Of course, the option is always going to be too close to the bone and run the needle to the bone. Inject a little bit, withdraw, move the skin up, and go back down again in the direction of the anus.
Dr. O'Berty did this the other day. He put 2 rows of skin wheels. The spot where he went and did it, he injected it with one needle, injected just over the peritoneum, and then went back. If I'm not mistaken.
I haven't watched, so there's really not much argument about how to do this block. There's some other things you can do. You can do the pubic hairline, you can do it with a straight line up here. To explore again the visceral cutaneous reflex, we have some input on the tissues underneath. I find that helpful only in acute cases, if you have acute pelvic pain. That can be definitely relieved by doing the skin wheels. But if you have a chronic PMS problem or chronic problem stemming from this area, you need to do the injections. You know, and then the quarters are only an additional thing is only happy temporarily. So I never do those if I'm dealing with severe chronic pain. So I go straight, you know, do the scar in women, hysterectomy scar, and sometimes we do those very frequently, sometimes they're very contaminated, cotton powder and other things, those are the scars that cause most just some real crippling hip pain, where, you know, those are the cases that need to be most often. I travel 15 times, the first time they go 20 hours pain relief, the second time they go 2 days of pain relief, the third time 2.5 days, and then 3 days. It's getting a little bit bigger every time, but it's not doubling, you know, and you just need to keep going at it until it's done. And it will get done. And if you go long enough, you get the permanent injuries, and if you follow the steps that we can.
Endometriosis, urinary fibroids, there's also no problem.
This is one of the main injections. Thyroid, tonsils, sinuses, chest, pelvic injection. You need, if you decide to go with neurotherapy, don't shy away from this procedure. It's so important. And there's almost no point in starting neurotherapy if you're not deciding to do this one. And I want you guys to be confident when doing this. If you follow the instructions, that the key, you put your lead parts, you have your artery straight here, and you use the right needle, you're not going to get any trouble with it. And it's such an important injection. In men, Hopper combines it with a dual injection, and we quickly demonstrate that one. The epidural injection now for us is one of the most frequently used ones for low back pain. A wonderful procedure, it's simple, it's safe.
Before you go on, can I ask you more questions? When you do the transvaginal approach, or the kind of skin, you go at 5 and 7 on the surface. And you notice that when you're doing it on men, you notice that there's a little bit of increased resistance as you go through the prostate cancer.
If you do, let's talk about the rectal injection of the prostate, because I started doing that one again more quickly than the previous approach. And rectal one is a little bit more messy, but very simple. I put the patient on the side. Why don't we just kind of fake it here through your pen? Would you pull everything up and turn away from me? Come over here. This is the way I do the transvaginal prostate, which is very safe and very simple to do. And please don't shy away to do this one. You have gloves on both fingers. You need to have your nurse there in case you forgot something. But once you add it, you can't go back and change your needles or pull something out of the cabinet that you forgot. So it's good to have your nurse in both of the procedures there. You take the finger off the left hand and stick it in and feel for the prostate where the prostate is. Most important. Then you go in lateral to the anus, and I go more like 3 and 9 o'clock. You know, but there's different ways of doing it. You get a fairly long needle, at least 3.5 inches. You do this until you get you clean with your brown stuff around the anus. You have your finger on the prostate, normally the prostate is, and you insert the needle sideways, side from the anus, so you don't get the needle contaminated and get a bit. It's lifted on slowly, move it forward towards where you feel the prostate. When you reach the prostate capsule, there's going to be a resistance or a rubbery you pump the needle out to the rectum on the way to the prostate. This means you pull the needle back and take a new needle because it's the most likely to contaminate.
What's the difference?
Well, you just have your finger in there and you feel actually when the needle comes against the glove, higher up. So you want to feel like always stay with the needle away from it. You feel usually the tissue changes, the needle comes anywhere close to your finger, you feel the tissue bites and outputs the finger. And it's the way when you do it, it's a very simple procedure. There's really no magic to it. You feel it very distinct. You feel the prostate, you know where it is, you guide your needle towards it. Again, use the same needle, 3.5 inch needle, if there's any blood tip that will avoid hooking to the rectum, because the rectum is the muscular apparatus around the rectum is fairly hard, and it's, with a sharp needle you pump easily through it and come back out inside the rectum. But if you take a very blunt needle, it'll guide itself along on the outside of the rectum, almost automatically falls into the prostate. This injection seems to be, in my opinion, a better injection, even though Hopper has avoided this approach, mostly because of time reasons. It takes longer to do it. You need sterile, you need gloves, you need lubricant. It's a little bit more messy, but it seems to be getting the better results. It's my feeling with it.
What's wrong with the approach going in just lateral to the perineum and anterior to the anus instead of lateral?
Well, you want the lobes of the prostate, there's distinct two lobes on each side, and you want to get from whatever approach you use, you want to get each lobe separately prepared.
And you go in each side of the perineum, but anterior to the anus instead of the side.
You can do that.
What's wrong with that?
There's nothing wrong with that. It's just, it makes no difference. Once you have you done these, I mean, it doesn't really matter where you go again. It's so easy to direct the needle from there. Anyway, towards the prostate, you can go almost behind the anus and do it from there. And you do whatever is easy from your position where you're sitting. Whatever is close to you. If there's pimples, go away from the pimple. If there's any fissure or crack, also go away from it so you avoid contamination. And that's more important, where you do whatever is comfortable with you, so you can feel the prostate. You have to have muscles on the prostate. You feel when you get into the prostate, you have your finger on it, and you get the needle on it, you feel it moving, and you try to move away from the needle because the needle is getting blunt. So you're playing it a little bit, and then you break into it. It's a very distinct feeling. When you don't get into the prostate, you still get sometimes the needle is too short, you want to try to fall as you make it, or you make the point needle too short, or you get slightly next to it. Rather than correcting my needle placement, fishing around, I inject a rather large amount of local anesthetic again, get close to the prostatic plexus, and still get my results from them. So it has to be intraprostatic, and it's really an important point in all cases. In some cases, you treat a true chronic prostatitis, you have to use something. If you treat the prostate clearance field for migraine or whatever it is, migraine, chest pain, heart attacks very frequently, you have to keep the prostate. I think the clearance field is close, it's enough to get close to the prostate. So there's those two aspects to it. And I'd like to quickly show you the dual injection. And then we're going to do the last thing here. You might volunteer quickly for that one. What you, the spinal is stomach. So with the dual injection, that's almost a must to treat low back pain. But we do it differently. Again, we use a larger amount of local anesthetic than neurotherapists use. Neurotherapists use 1 to 2 cc. I feel if you bother to get in that space, you should use a larger amount. I use 50 cc. I don't know how much are you using, 20?
I use 30. Does it use all the time?
Yeah. Well, I
get a
prefer.
motor block if you use that much again.
No, not with 0.5. I prefer that they do an injection of Novocaine. It gives much more dramatic there's a little bit of anger in the sacrum. The neurotherapists in Germany do this procedure by having the patient bend over like this and do it basically in a standing kind of position, which is very nice, but user unfriendly. If or you think of fainting or so, it's not a nice position to have a patient in and then think of fainting. The caudal hiatus is located up at the upper end of the anal fold. In women, usually there's a distinct anatomical difference between men and women. In men, if we follow this here, it's the upper end of the anal fold, and then the caudal hiatus is about half an inch or so above the end of the line between the two muscles, a little bit up. In women, if you follow the anal line, it's usually 1 inch down into the anus between the lines because of the pelvic differences. And the degree of needle insertion is, if you look at the patient when they're lying there, he has a fairly good posture with a nice lordosis. If they have a nice lordosis, the angle is about 45 degrees down, one steeper down and one steeper ahead. If women have very strong lordosis, they can be up perpendicular to really reaching the caudal hiatus, and people with a very flat pelvis, over the reversal of the curve, you have a flatter angle. So when you feel, you can do this with a 1.5 inch 25 gauge needle. I use a finer needle and Java waves and all that, which I should of course recommend. But I'm giving you what the neurotherapists are doing. They use just a 1.5 inch 25 gauge needle without any problem for most people. They go in, you contact bone, you fish around a little bit until you find the cartilaginous covering of the caudal hiatus with a sort of rubbery substance, and as it slips through, there's a little resistance and the needle slips through in the epidural space, and then you're home and dry. That's where you put your local anesthetic. With this procedure, I always use a fresh blood control anesthetic, and that's really sure that the hand and as you start doing it, I recommend you start out at about 5 cc for the first few that you do, 5 cc, 0.5%. As you get more confident with it, you have your nurse there, and either like I'm using a little plier-like thing, I put 10 cc syringe, I put 10 cc in, and then hold the needle with the plier, and unscrew it to the syringe, take another 10 cc syringe, and keep giving one to 150 cc in there. That gives one dramatic relief for low back pain. Again, if you combine two approaches, one is the electromagnetic approach by putting a local anesthetic in there by using a large volume. We also apply the model from this morning. We're using a structural approach with a large volume of fluid in the epidural space. We're separating adhesions between the nerve root and scar tissue within the epidural space. Everyone with a herniated disc in the scar tissue in the epidural space that forms tentacles that adhere to the nerve root, which is the most common part of low back pain. Period. And by pushing a large volume of fluid in the adhesions at the nerve root, you detach the nerve root from the adhesions, so it's free range of motion again, and you can gets used for when you do a prostate. You can probably also do this. When you treat hemorrhoids, it's nice to do a little epidural with it. When you treat pelvic pain, it's nice to do an epidural along with it. Anything in the segment, it's nice to do an epidural. The lumbar sympathetic block is very important for any type of trouble in the leg, sympathetic dystrophy.